Hey everybody, Dr. Rafich here from Vet Triage. This is a very cool paper. It is a small case series, but we'll go through it. This is I believe the last article in this issue. No, we're almost there. February 2022. This is the application of locking compression plates as a type 1 external fixator to treat unilateral mandibular fractures in 4 horses and 1 camel. The study comes out of Berlin, Germany. So, this is what they're talking about here. Normally, this type of plate is placed on the bone underneath the skin and muscles. And instead, for these cases, they place them outside like a makeshift external fixator. There are 4 types, or maybe there's more now, I don't know, because these external fixators get very complex. But 4 types of external fixators, and they go from simple to complex as you go from 1 to 4, all for different reasons. So this is very, very cool. And then when you look at the x-rays for this, let me see if I can get it here. Let's see, there we go. This is a CT scan of one of the horses, and here's the fracture line. And then look at this, a very long bone plate, some screws, and they left these parts empty because probably because of the combination of the orientation of the fracture as well as the trying to avoid the roots of the teeth. But what a wild repair! And again, this is outside the skin. This is not on the actual bone. So pretty wild, pretty crazy. I love this kind of stuff because it's just novel. So yeah, let's go through it. So the objective was to describe a novel fixation for open, unstable, unilateral mandibular fractures, applying a locking compression plate, which is what that plate is, as an external skeletal fixator. 4 horses, 1 camel, short case series. Methods include a 4.5/5.5 narrow locking compression plate applied externally above the skin and combined with intraoral tension band wiring. So for the other cases, they had wires that went between the teeth to also help with the fixation. Implants were removed 3 to 12 weeks after, and long-term function with a median of 13 months was good in all cases. Conclusion was stabilization of mandibular fractures with a locking compression plate placed as an external skeletal fixator led to a good outcome. The use of longer place position more caudally and in a ventrolateral position seems associated with surgical site infection and pressure necrosis of the skin. Introduction. 1 second, guys. Perfect. Okay. Introduction. Mandibular fractures are common in horses and camels and are usually caused by traumatic incidents. Most are open to the oral cavity, and they are often associated with a skin wound at the site where the traumatic impact occurred. Unilateral, stable, and minimally displaced fractures can be treated conservatively. Unilateral fractures, if they are unstable, comminuted, or have malocclusion, are treated surgically. Internal fixation using plates and screws in combination with intraoral wiring is most stable. The current concept for surgical fixation of unilateral, unstable, or comminuted fractures of the horizontal ramus of the mandible in large animals is based on intraoral tension band wiring, combined with the application of locking compression plate at the ventrolateral, or lateral aspect of the bone. Surgical site infection related to soft tissue injury and contamination is a common sequela following internal fixation of open mandibular fractures. Alternatively, you can use an external skeletal fixator. Closed reduction of the fracture can be achieved with little tissue manipulation. Foreign material at the fracture site is minimized. Additional advantages include access to wounds that are typically present and easy implant removal. Recently, a polyaxial pedicle screw external fixator was evaluated biomechanically and clinically in 3 cases of mandibular fractures in horses. Locking compression plates are principally designed for internal fixation. The rigid engagement of the locking head screws in the threaded portion of the combi hole allows for the compression plate to be positioned at a chosen distance from the bone. The biomechanical properties of the locking compression plate external fixator have been investigated for the use in human surgery where these constructs are mainly used for the treatment of open tibial fractures. These constructs show decreased stiffness compared with internal fracture fixation, but the advantages of external fixation justify its application in selected cases. Very well written. Materials and methods. These fractures were caused by a fall or a kick or a crush injury, and they were usually acute within 24 hours. They had skin wounds or mucosal lesions. They had digital radiographs or CT scans. They were comminuted fractures and simple fractures. They were displaced. They were involving the horizontal ramus of the mandible and sometimes the vertical ramus as well. The incisive bone and maxilla were involved bilaterally in another case, and sometimes the teeth were fractured. We're just going to summarize these cases, like broadly speaking, because it's just too much detail, and we really care about the basic fundamentals here. Treatment for preparation for surgery included some combination of flunixin, meglumine, amoxicillin, gentamicin, ceftiofur, xylazine, butorphanol, general anesthesia, diazepam, ketamine. They were intubated orotracheally or nasotracheal, and then isoflurane. They used narrow 4.5/5.5 locking compression plates with a 5.0 locking head screws for fracture fixation. Some were 10-hole plates, 12-hole, 16-hole. Plates were bent to fit the contour of the mandible position with respect to location of the wounds and fracture configuration. Some were ventral, some were ventrolateral. At least 3 screws were placed on both sides, but we have the one case where they placed 2 screws, and that's in this case here. That's because that's all the room that they had. They used radiographs to guide them for fracture reduction and plate contouring and implant placement. Let's see. And you can see in some of the radiographs that the roots of the teeth were contacting the screws as well. Post-op management: flunixine, meglumine, omeprazole, sucralfate, polyhexanine solution for the wounds. All right. Here's a picture of not only the bone plate, but you can see the wiring there as well for this horse. Pretty crazy. Okay, results. Post-op complications prior to plate removal include drainage from the screw skin interface, also hypergranulation. We had some screws that contacted the teeth, sequestrum, loose fragments. One had broken implants, no evidence of plate loosening though. The other one had, another case had superficial pressure necrosis of the skin and subcutaneous tissue. Pressure necrosis, abscess, fistula. Again, these are just general complications they found with these. None of them are surprising, and you would expect that with this type of repair. Here's another case. And this is the one that we have on screen. Okay. Discussion. The biomechanical impact of plate positioning for the fixation of biaxial interdental mandibular osteotomies was evaluated in an ex vivo model and identified a superior stiffness for ventrolateral locking compression plates when compared to ventral or ventrolateral dynamic compression plates. In this study, which was ex vivo, ventrolateral positioning of the locking compression plates was not compared to ventral positioning, and constructs were tested without intraoral tension band wiring. For this reason, and because of external application of the locking compression plate in this study, the biomechanical situations evaluated by that study are not directly transferable to this current study. Ex vivo studies would be required to clarify biomechanical characteristics of different positions of the construct used here. No obvious clinical disadvantage with either position were observed in this report, meaning laterally versus ventrolaterally, or just ventrally. Control CAT scans found apical mineralization of the distal pulp in one of the teeth. Similar images are described in horses with apical infections, and they most likely represent a reactive or reparative response of the dentino-pulpar complex to an insult. These could have been caused by contact of the screw in the tooth root or the initial fracture of the tooth. Other teeth involved in the fracture did not develop pulp mineralization, making this possibly an iatrogenic etiology. The interference of the screws placed in the ventrolateral aspect of the mandible with tooth roots is a known risk. Here's another repair as well. See on the top view, the CAT scan, showing the fracture with the arrows, and the bottom is the repair, with a combination of the plate, the screws, and the tension band wiring. The need to insert locking head screws at a 90-degree angle to the external fixator locking compression plate construct makes avoiding the tooth roots challenging. Other fixation methods allow placement of screws at variable angles for internal fixation with locking compression plates. Locking head screws were combined with cortical screws that allows you to, so locking head screws have to be in 90 degrees to the plate. That's how they lock into the plate. Cortical screws don't have to be, you can angle them, but then they don't lock into the plate. Recently, a pedicle screw external fixation device was evaluated biomechanically and in 3 clinical cases with no interference of implants with tooth roots reported. A type 1 external skeletal fixator construct using 5.5 millimeter cortical screws connected with a polymethyl methacrylate bar has also been described for stabilization of mandibular fractures. Another option to avoid contact of implants to tooth roots and mandibular fracture fixation would be the pinless external fixator, but they don't make that anymore. Polyaxial pedicle screw external fixator had been reported, and then in contrast, for human open and closed tibial fractures stabilized with the same construct used here, superficial screw tract infection was described in 7.1% of cases, but a clean environment and the option of bandaging are possible reasons for the difference between species and fracture sites. As increasing the number of pins generally increases the stability of the construct, the advantage of increased stability must be weighed against the risk of pressure necrosis to the skin. In other reports of external fixators, they were removed at 5 to 6 weeks at the earliest. Implants were not used as intended by the manufacturer in this series, but the rationale behind using this construct in selected cases is based on some specific advantages over internal fixation. With the construct, the amount of foreign material in the infected area can be minimized. Internal plate application often requires excessive soft tissue dissection, whereas the external skeletal fixator and locking compression plate in the study has potential to reduce trauma to structures like the parotid duct, nerves, and blood vessels, and may help preserve vascularization of the bone and soft tissue support. Adopting this method of the construct for the stabilization of mandibular fractures in large animals was further supported by biomechanical considerations. The distance from the connecting sidebar to the bone is minimal with the construct compared to other external skeletal fixation constructs. This should be an advantage as the stiffness of the pins is inversely proportional to the third power of the distance of the sidebar to the pin bone interface. Here's another final image here. So very cool. I like when people do this kind of stuff. It takes some confidence to do it. Obviously, we want more cases and studies to show all the advantages and disadvantages, pros and cons of this, but love this kind of stuff. Keep it up. Especially with large animals where, you end up euthanizing them because you can't fix a fracture. So it's good they're being brave with this type of stuff. All right, thanks for supporting the channel. We've got one more in this issue, and then we'll go to the next one. Take care.